important to us. So, with that as your preface, I will tell you we took the standpoint of the nurse. So we were really interested not in what the managers necessarily were telling us what they knew happened off-peak, but what did the nurse at the bedside know about what was going on. We really don't test hypotheses. This is very empirical. We are simply describing, through the words of the people we interviewed, what actually happened. We have what we call a problematic in sociology. That's the term used. This is our problematic. We might call it in nursing a research question. What do nurses know about their work and the environment in which it takes place that would help us account for what Gretchen's already told you were some pretty startling statistics on mortality off-peak? We wanted to know the challenges, which again is very similar to the small problems, those small troubles. We wanted to know those managerial, economic, and healthcare policies that influenced what was going on. You know, those people who weren't even in the room, but because of what had happened elsewhere, those effects were taking place at the bedside. We conducted 57 interviews with over 70 nurses. We recruited them primarily from hospitals in North Texas and also the Texas Medical Center in Houston. We conducted interviews from December of 2008 till just recently, June of 2010. And we asked the nurses simply, what do you do here at night or on the weekend? And tell us about that. And all you have to do is ask the first question. We have over 7,500 coded segments of text that we have analyzed initially, and we're now working and digging, as they say, drilling down. Thought you might be interested in the codes that we are using to code that text, some of the issues that nurses, now all we asked was, what do you do here? And here are some of the things they're talking about. They're talking about patient acuity, bed control, that is enormous, benchmarking, budget, business, the charge nurse role. That came out as a surprise to us, how much talk there was about the charge nurse. The hospitalist, hours per patient day, the matrix, and we'll show you one of those in a minute, PCAs or their lack thereof, health policy, problems, productivity. If I had to pick one thing, and that's one of the things I'm going to tell you in just a minute, this is one of the biggest issues that nurses off-peak face, is the productivity and the staffing. Telephone calls were certainly a problem when they had to get care from a distance from another provider, but I thought the breadth of their issues that came up in their talk was important. Just a few of those policies and procedures and ruling relations that happen, like the franchise agreement with my breakfast restaurant. The things that are affecting nurses are things like the ANA principles of staffing, the state bill that was passed and went into effect in September 2009 that mandated that every hospital have a nurse staffing committee. Hospital budgets. This is an enormous influence over what goes on actually at the bedside at 2 a.m. Productivity targets, the staffing matrices, the work schedules, who works, when, and with whom, who gets assigned to which patients, and is there any continuity, and then of course quality indicators. So all of those things go into the juggling that a nurse must do just caring for a single patient. So let me just give you as an example, sort of my equivalent of that point of sale cash register, the things that are influencing nurses at the bedside. This is a fictional staffing matrix. It did not come from a particular hospital, but it is very much similar to the ones we saw, where you'll see on the far left-hand column the census, so the number of patients that are on that unit, determine everything else that's to the right, the number of RNs that are scheduled, and I will stress scheduled, the number of aides, whether or not there's a unit secretary, whether or not there's a charge nurse, and in this case there was always just one, and the total number of staff, both day and night. And you will see as you go down that as the census increases, there's certainly more staff, but you will also see across that the AM staff is greater than the PM staff. And the assumption, again, let me stress, because I didn't say it as clearly as I needed to, we interviewed nurses in ICU units. These were not medical surgical units. This was an area where you would expect need of patients to be 24/7, not changing at 7 p.m. So this really drove a lot of what the nurses were dealing with, not only how few or how many staff they had, but what the mix was, whether it was only the nurse having to do all the care without a PCA, plus answer the phone, and so forth. So this was a huge problem. Let me show you this one other thing that was certainly driving from a distance what was happening to the nurses and their patients at the bedside. This is the productivity chart that, again, is not from a particular hospital, but that is an example of, came from Premier's website. But it'll sort of tell you what a nurse manager is responsible for. What you see here is a control chart for his or her productivity, which based on that staffing matrix. Are you keeping your staffing within the bounds that are allowable for the number of patients you have over time? And you'll notice that these are dated by pay periods. So they are aggregated. So a nurse manager is telling us, and the staff are telling us, that they may have a higher acuity and call in more nurses. But by the end of that pay period, where they know this is going to be examined by the higher administration, they start to cut back when their nurses ask for more staff. And they say, well, remember, you had those last week, but now we're going to have to tighten our belt and get ready to be evaluated. And so you'll see also up at the top, the second line, this department is on the watch list. When you go outside of that control chart, that band, you become a focus of scrutiny. And so it is incumbent upon the nurses to justify why they need the staff they need to care for the patients, not the other way around. The administration doesn't have to justify why they don't get the nurses. So you see that some of these pressures that are happening outside of the patient's room trickle down, if you will, and sometimes come crashing down at the point of care. So let me just tell you that. I'll reiterate that what Gretchen's already said, the majority of care really is delivered off-peak. It isn't a minor part of the work week, it's the majority. In Texas, I can say that I don't see a lot of impact from the state legislation, and that even though it was enacted in 2009, we'd had a previous policy that was just very much like it that was passed in 2004, and still nurses don't feel empowered to talk about how many staff they need. This is on our website. It's our recommendations from the study, and you can look at it as a foreground or background depending on how you want to view it. But one of the most critical things that must happen is the engagement of the off-peak nurses in any kind of policy or procedure discussion that's going on in the hospital, and in the empowerment to determine what their patients need and not to have the full burden of the workaround on their shoulders. We really believe, and this is the contribution of the economists, there are two firms, or if you will, two hospitals. There's the one that happens peak, and there's the one that happens off-peak. And not only are the services delivered, we expect the patients to be different, as Gretchen's implied. That's the way it appears from the way we've organized our care. So far, we've had a number of presentations. We've got 2 publications that have already come out and a draft of an article on the risks for the hospital to cooperate with clinical researchers to really publish the findings, because we found that to be something that requires a lot of trust, and it is a great risk. I didn't know Nancy was going to be here, but here's one of our goals, is to be on, somehow have this issue of off-peak care be part of the patient survival guide in U.S. News and World Report. This is our website. We'd ask you all to visit us. The URL is nursingopen247.com. It's nursingopen247.com. On it, you'll find tools for change. You'll find videos. We even have one with Dennis Quaid. I'm so proud, not because of us, but because of his campaign for quality. Thank you very much.
Excellent. So we still have time for a few questions. Would like to start. Yes.
Hi, Patty. This work is really important, and as I told you, we have a doctoral student that's working with us, beginning to look at that. And one of the things that we've discussed a lot is the idea that on some off-peaks for new grads, that the workload might actually be, it might be a better place to learn. Did you find anything regarding that?
Yes. We certainly did hear that people start out in the off-peak shifts primarily. Some people would argue that it's a better place for a new grad because there's less hubbub, there's less going on in terms of physicians and procedures and things like that. I did not see in the data that that was the case. It seemed as though you were putting the new grad in a real predicament because some of those workarounds that we talk about, if a nurse takes that seriously, he or she may push way beyond their practice limit in order to get the patient what they need. Hang blood, order prescription drugs, do all kinds of things to get the patient what they need and still keep the physician from being angry at being waked up, say if it's in the middle of the night. So to us, I think it's fair to say that seems to be a very hazardous place to put a new grad.
In your ethnography, did you conduct any observations in concert with the interviews? And were the interviews conducted in the workplace?
The answer is no to both. We opted not to do observations to allow us to get through 3 IRBs and collect as much data as we did. We admit that maybe that would have added richness to our data, but we decided it would be more challenging. And to make the nurses feel safe, the interviews were all conducted off after hours, so they may have been conducted at the hospital. But one of the challenges of interviewing staff that's working 7P to 7A is that it really aren't interested in hanging around talking to you at that point. So we ended up doing a lot of shifting to phone interviews, where we didn't even have the advantage of having the face-to-face interaction, but we're able to get more of their time rather than trying to compete with their needs to be home to provide childcare or family support, whatever. So, but intentionally, because of the commitments we made to the institutions, we didn't do it during the work day.
So first, I want to congratulate Kathleen and Bob and both of you, Patty and Gretchen. Just terrific work. I'd love to hear your next steps.
Well, as part of our dissemination, we held 2 conferences for nurses in Dallas and in Houston, and we started looking at how do we develop a tool that we can gather more information about the actual off-peaks. And there is a tool out there developed by Dr. Sulkin, who's looked at off-peak, his sort of impressions of it. It's called this SWAN, which is the Safety of Nights and Weekends. But really looking at the factors he's identified from his experience as a physician executive of what really matters, and having people look at that and taking his instrument to the next level, which is basically validating it and actually testing it across levels of organizations to see what do they think matters. We had some very interesting dialogues at our conferences with people saying, well, are there administrators available in nights and weekends? And the nurse's perception of an administrator being available is that there's a house supervisor in the house. That's not an administrator who has ultimate accountability for what happens in the facility.